Continuing chapter 31, dislocation of the shoulder. So your shoulder is also called your glenohumeral joint. This is where the head of your humerus meets the glenoid fossa of the scapula. A lot of times in the dislocations, your humeral head is going to dislocate anteriorly, and it's going to end up sitting right there in the front of the scapula because you end up having forced abduction and external rotation of the arm. Shoulder dislocations are extremely painful. The patient will guard the shoulder, try to protect it by holding it in a fixed position, typically going to be away from the chest wall because every time you start bringing that into the chest wall, it just causes a lot of pain. So trying to splint the joint can be interesting. Try and splint it where the patient's comfortable. You may need to place a pillow or a roll of blankets between the arm and the chest to fill up that space so that you can stabilize against it. Apply a sling to the forearm, wrist support to help pull the weight up, and then you can use a sloth. Oftentimes you're going to transport the patient in a seated or semi-seated position. Fractures of the humerus either occur proximately in the midshaft or distally at the elbow. Oftentimes it's going to be from falls. It's very common amongst older people. Fractures of the midshaft occur more often in younger patients, typically because of a violent injury. With any severe angulated fracture, you may need to apply some traction to try and realign it before splinting it. In order to do that, you're going to grasp the side of the fracture with one hand, with the other hand grasp the two humeral condyles just above the elbow and gently pull the limb in line with normal access, and then splint with sling and swath. Elbow injuries, fractures, dislocations often occur around the elbow, and different types of injuries can be hard to distinguish without true x-ray exams. You can get a fracture of the distal humerus, which is actually the olecranon process of the ulna. It can be from either direct or indirect force, often associated with lacerations and abrasions. Oftentimes you're going to get fragments that are going to rotate pretty significantly. You might have a severe deformity. Swelling often occurs rapidly, often pretty severe. Dislocations of the elbow typically occurs in athletes, rarely seen in young children because of when they go to slip and mom's got a hold of their hand or dad's got a hold of their hand and they pull up, you can get it's called nursemaid's elbow. Oftentimes the ulna and radius are going to be displaced posteriorly relative to the humerus. It makes the olecranon process much more prominent, and there could easily be swelling and a significant potential for vessel or nerve injury. Fracture of the olecranon process of the ulna. This is, again, going to be actually it's the proximal head of the ulna. The patient's going to be unable to actively extend the elbow because it's going to hurt. Fractures of the radial head. This is often misdiagnosed. The fracture generally occurs as a result of a fall on an outstretched arm, and oftentimes it's just not something that we pick up on. Attempts to rotate the elbow or wrist end up causing discomfort, but for the most part, it doesn't show like the other ones do. Care of elbow injuries. Elbow injuries are potentially serious. They require pretty careful management. You always want to assess CMS periodically in patients with elbow injuries because as it starts to swell, it could easily cut off nerve function, blood vessels, etc. If you find good strong pulses and cap refill, splint the elbow injury in that position, adding a wrist sling if that's helpful. Any sort of cold, pale hand, weak or absent pulse, poor cap refill, it's likely that blood vessels have been injured, so you want to go ahead and transport quickly. Fractures of the forearm, fracture of the shaft of the radius and ulna are pretty common in all age groups, most often seen in children and older people. Usually both bones break at the same time because of a fall on an outstretched hand. An isolated fracture of the shaft of the ulna may result because of a direct blow to it. This is called a nightstick fracture because you tend to put your arm up to protect yourself and then get nailed. Fractures of the distal radius, which are common in elderly people with osteoporosis, are known as Cole's fractures. They also use the term silver fork deformity because there's a pretty distinctive appearance of the patient's arm. You want to go ahead and stabilize. You can use padded boards, air vacuums, pillow splints, etc. You want to try and elevate the extremity if possible to relieve swelling. Injuries of the wrist and hand can range from dislocation to sprains, often have to be ruled out by radiographic examination. Dislocations are usually associated with a fracture, so you get a dual issue there. Other common injuries, isolated non-displaced fractures of carpal bones, especially the scaphoid there in the wrist. Any questionable wrist sprain or fracture should be splinted and then evaluated in the ED. Hand injuries vary widely. Some do have potentially serious consequences because the fingers of the hands are required to function in such intricate ways. Any injury that you don't treat properly can result in permanent disability as well as deformity. We're not popping dislocated fingers back into place. If we have amputated parts, we take them along with us in the hopes that they can be reconnected. Fractures of the pelvis often result from direct compression in the form of a heavy blow that laterally crushes the pelvis. The blow may be from a motor vehicle crash, a weapon, a falling object, fall from heights. You can get injuries to the pelvis caused by indirect forces, but it's definitely more common. Keep in mind that not all pelvis fractures are the result of violent trauma. Fractures of the pelvis may be accompanied with life-threatening loss of blood because there's a lot of massive blood vessels in there that can very, very easily be injured along with the bone. And you have a lot of space. Several liters of blood can drain into the pelvic space and up into the retroperitoneal space. And you can get significant hypotension, shock. Sometimes your patient can even exsanguinate internally because of this. So you want to make sure that you take action to get the patient treated because you may not see any bleeding. If a patient has sustained a high velocity injury, if they're complaining of discomfort in the lower back or abdomen, just think pelvic fracture because you may not see any deformity, you may not see any swelling. So the most reliable sign of a fracture of the pelvis is going to be tenderness or instability on firm compression and palpation. There's a couple of different ways you're going to palpate. You're going to palpate in, you're going to palpate back. You can do a little rock of the hip as well. And then the picture all the way to the right is checking the pubis symphysis, so where those bones come together in the front. Dislocations of the hip are not going to be isolated most of the time because that ball and socket joint is very, very stable. So it takes some pretty significant force to pull it out. Most dislocations of the hip are posterior and often result because of a motor vehicle crash in which the knee meets the dashboard and there's a direct force that runs up the entire femur and that whole thing is driven posteriorly. You should suspect a hip dislocation in any patient that's been in MVC that has a contusion, laceration, or obvious fracture in the knee region. Posterior dislocation is frequently complicated by injury to the sciatic nerve, which is basically located directly behind that hip joint. It's the largest nerve in the lower extremity. It controls the activity of the muscles in the posterior thigh and below the knee, and also the sensation for the majority of the leg and foot. So when you end up compressing or stretching that, you can lead to either partial or complete paralysis of the nerve. Dislocation of the hip is associated with some pretty distinctive signs. The patient will have severe pain in the hip, will strongly resist any attempt to move the joint. The lateral and posterior aspects of the hip will be tender on palpation, and occasionally sciatic nerve function will be normal at first and then slowly diminish over time. As with any other extremity, don't attempt to reduce it in the field unless medical control ends up telling you to. You want to splint in the position of deformity, place the patient supine on a long backboard, which is often going to be pretty painful for them. Support the affected limb with pillows and rolled blankets. If they can hold their leg up and that feels better, go ahead and give them that proper support. Secure the entire limb to the backboard with long straps and then transport. Fractures of the proximal femur. They're very common, especially in older people, patients with osteoporosis. The break often goes through the neck of the femur, kind of right below that ball and socket joint, and then across the proximal shaft. Patients display a very characteristic deformity. The leg will externally rotate. The injured limb is usually shorter than the uninjured. Patients are unable to walk or move the leg, and the hip region is usually tender on palpation. If you end up causing a little gentle rolling of the leg, you end up kicking up the pain, but often that's not going to do any more damage. You want to assess the pelvis to make sure that that's not what's injured. Assess CMS, splint the lower extremity, and then transport. Femoral shaft fractures. Fractures of the femur can occur in any part of the shaft, from the hip region all the way down to the femoral condyles just above the knee. Following a fracture, the large muscles are going to try and spasm to quote unquote splint that unstable limb, which causes a lot of pain, can cause significant deformity, and usually that limb is going to shorten significantly because of it. Fractures may be open here, causing the bone to protrude through the skin. Again, we're not putting those back. There's often a significant amount of blood loss. You can get up to 1,000 mils after a fracture here. So it's very common for hypovolemic shock to form. Because of the deformity, bone fragments can easily penetrate or press on important nerves and blood vessels, which then lead to significant damage. So make sure that you continue to assess CMS. Cover any wound with a dry sterile dressing. If you have a sign of impaired circulation, such as numbness, pale, cold, and unable to find a pulse, you may want to apply gentle traction or traction splint to try and bring those bone ends back together to restore circulation. We'll go ahead and stop here.